Good morning all. We'll be discussing part 3 of sole question paper of subject periodontology. It's a Patan University for the year 2019. In this I'll be discussing short notes. The question paper is given here on the screen, section 1, and questions are smoking and its effect on periodontium, drug induced gingival enlargement, classify and write in detail composition and mode of attachment of calculus, describe the clinical, microbiological and radiographic feature of localized aggressive periodontitis, trauma from occlusion. Last question. Classify and write in detail composition and mode of attachment of calculus. Calculus definition is an adherent calcified or calcifying mass that forms on the natural teeth surface and dental prosthesis. Old terminology is odontolithiasis and tartar. Classification. Depending upon the position of gingival margin, calculus is further divided into supragingival and subgingival calculus. Supragingival calculus. The calculus that is located coronal to the gingival margin is supragingival calculus, and therefore it is visible in the oral cavity. It may be localized or generalized. Color is usually white or whitish yellow. The color is influenced by tobacco or food pigment. Consistency is hard and clay-like consistency, and it can be easily detached from the surface of tooth. Just because it is formed by the deposition of salivary component, it is most commonly seen where the ductal opening of salivary glands are there. For example, buccal surface of maxillary molar, as the saliva flows through the Stenson duct, and in the lingual surface of mandibular anterior teeth, where saliva flows through the Wharton duct. Bartholin duct empties on the lingual surface of lower incisors. This is referred to as salivary calculus because it is derived from the saliva. Subgingival calculus. As the name suggests, it is lying below the crest of marginal gingiva, so it is not visible. Color is dark brown or greenish black in color because the component of the calculus it is derived from the blood or gingival crevacular fluid. Consistency is hard and very dense. It is flint-like consistency because it is slowly firmly attached to the tooth surface. It is also known as serum calculus because it is derived from the blood serum. Inorganic and organic composition. In inorganic component, calcium, phosphorus, carbonate, sodium, magnesium and fluorides are there. And these inorganic components, they form various crystals. The crystals are hydroxyapatite, magnesium whitlockite, octacalcium phosphate and brucite. The crystals will be formed from this inorganic component. Now coming on to the organic component, mixture of protein, polysaccharide complex, desquamated epithelial cell, leukocytes and various microorganisms. Carbohydrate, in carbohydrate, glucose, galactose, ramenose, mannose, protein and lipid. Attachment of calculus on the tooth surface. 4 modes of attachment are there. Attachment by mean of organic pellicle. First mode is by organic pellicle. Next is attachment on the mechanical interlocking in the surface irregularities. The surface irregularities that are there on the surface of tooth, which is produced by resorpting lacunae or caries, in this mechanical defect, the calculus will form mechanical interlocking and it is firmly attached onto the surface irregularities. Now close adaptation of calculus under surface depression to the gently sloping mounts of unaltered cementum surface. Now calculus penetration in the cementum. Bacteria moves into cementum which get calcified over the time. Second question, describe clinical microbiology radiographic feature of localized aggressive periodontitis. Definition of aggressive periodontitis is, aggressive periodontitis comprise a group of rare, severe, rapidly progressive form of periodontitis often characterized by early age of clinical manifestation and a distinct tendency for cases to aggregate in a family. That means the disease is very rare. The key words are, it is very rare, disease is very severe, Rapid bone loss will be there, and it is seen in early age, and the cases will be running in the family. That means genetic basis of disease will be there. Classification given by Lang: localize and generalize. Now, clinical feature of localized aggressive periodontitis are circumpubertal onset. That means onset is near about puberty. Localized involvement of first molar and incisor will be there. Lack of clinical information despite the presence of deep periodontal pocket. Amount of plaque on affected teeth is minimum. Distolabial migration of maxillary incisor with concomitant diastema formation. Increased mobility of first molar. Sensitivity of denuded root surface to thermal and tactile sensations. Now, the disease is normally seen around the age of puberty. That means it is seen in very younger age, and it will be affecting molars and incisors. Severe bone loss will be there. Mobility of first molar and incisor will be there. Because of this, diastema will be there, but lack of clinical inflammation and very minimum amount of plaque will be there. Microorganisms associated with the disease are: most important bacteria associated with the disease is Aggregatibacter actinomycetam comitan and Porphyromonas p gingivalis. And apart from them, other bacteria associated are bacteria and spirochete associated is given on the slide. Radiographic feature: vertical loss of alveolar bone around the first molar and incisor. It's a classical diagnostic sign of localized aggressive periodontitis. Arc-shaped loss of alveolar bone extending from the distal surface of second premolar to the mesial surface of second molar, and mirror image will be there. Treatment: extraction of involved teeth if periodontium is very compromised, periodontal therapy along with the antimicrobial therapy, plaque control instruction, debridement with or without flap surgery, irrigation with chlorhexidine, home rinsing with chlorhexidine, bone graft, root resection, hemisectioning, and frequent maintenance visit will be given to the patient. Coming on to the next question, that is trauma from occlusion. Definition: when occlusal force exceed the adaptive capacity of tissue. That means occlusal forces are increased on a tooth and it cannot adapt with this increased force. This is known as trauma from occlusion, when occlusal force exceed the adaptive capacity of tissue. Etiology: malocclusion, temporomandibular joint dysfunction, faulty restoration, faulty prosthesis, faulty orthodontic treatment, parafunctional habit, dental caries and bruxism. All these faulty prostheses, they all produce excessive force on the surface of tooth, and because of this, trauma will be there. Two concepts are there. Glickman concept. According to the Glickman concept, the pathway of spread of plaque associated gingival lesion, the pathway can be changed if force of abnormal magnitude they are acting on the teeth harboring subgingival plaque, and he divided the area around the tooth in zone of irritation and zone of co-destruction. Warhol concept. Warhol gave the concept in 1976. He concluded that angular defect and infrabony pocket occur due to subgingival plaque and it is not related to trauma, and he refuted the concept of zone of co-destruction. Classification: acute, chronic, primary and secondary. Acute is of sudden onset. It is for shorter duration of time. For example, when we bite on some hard object, this is known as acute trauma from occlusion. It results when an abrupt change in the occlusal force such as that produced by biting on a hard object. Chronic trauma from occlusion. Chronic, it is produced over a period of time gradually, and it is more common than acute form, which develop from gradual changes in the occlusion produced by tooth wear, drifting movement, extrusion of teeth combined with parafunctional habit such as bruxism and clenching. Primary. Primary trauma from occlusion, in which periodontium is healthy but forces are abnormal. Increased forces are there. And in secondary, periodontium is compromised but the forces are normal. Primary, when trauma from occlusion is a result of alteration in the occlusal forces, it is called primary trauma from occlusion. Secondary, when trauma results from reduced ability of the tissues to resist the occlusal force, this is known as secondary trauma from occlusion. Coming on to the stages of tissue response. First is injury, repair and adaptive remodeling. In injury, tissue injury is produced by excessive occlusal forces. When repair takes place, buttressing bone formation and lipping will be there. In order to buttress the bone, when excessive forces are produced, bone will try to reinforce itself by producing more of the bone. This is known as buttressing bone formation and lipping. An adaptive remodeling of periodontium results in thickened periodontal ligament, which is funnel shape at the crest and angular defect in the bone with no pocket formation. Funnel shaped widening of periodontal ligament and angular defect in the bone. Clinical sign: because of excessive force, mobility of teeth will be there, migration of teeth will be there, and in acute trauma from occlusion, when someone bite on hard object, cementum fracture, root fracture, crown fracture might be there, vertical impaction of food or wear facet as seen in bruxism, pain and discomfort of the teeth, thermal sensitivity will be there, Fremitus test will be positive. Radiographic feature: thickened lamina dura along the lateral aspect of root in the apical region and in bifurcation area, vertical destruction of interdental septum, root resorption, buttressing bone formation, increased radiodensity of the bone. Treatment: removal of etiological factor will be done. Treatment will be done according to the etiology. If the parafunctional habits are there, for example bruxism, the management of the parafunctional habit will be done. If excessive forces are there because of some restoration, then we should go for the correction of same. That means treatment will be done according to etiology. Management of parafunctional habit, if bruxism is there, occlusal adjustment will be done, reshaping of teeth by grinding, dental restoration, splinting of mobile teeth, selective grinding will be done, and tooth movement by orthodontic mean. Thank you so much.